Welcome, Gabriel. It's an honor to have you here today.
Thank you very, very much indeed, Rebecca. Huge pleasure to be here.
Great. Thank you so much. I know you rushed in from another meeting. So I understand that you were part of the World Health Organization team that was invited to visit China in February. Do you think you could share with us what were the things that struck you most about your visit there at the height of the pandemic in China?
I think that one of the most striking experiences was really that of the precipitous decline of transmissibility that is reflected in the daily number of reported cases throughout the country, but particularly outside of the original epicenter, Hubei province. And really appreciating firsthand from visiting the places, the hospitals, the clinics, and the neighborhoods, as well as government ministries, really appreciating how mainland Chinese colleagues have been able to make that happen. And I think that it's really a combination of essentially freezing mobility between provinces or between different cities within provinces, and even between different neighborhood levels within the same city. And then very quick and swift isolation of confirmed infected individuals and quarantining of their close contacts off-site, outside of the home, in designated or redesignated facilities. And then for the vast majority of the population who are not infected or close contacts of those who are infected, a combination of the medieval with the postmodern. The medieval is, of course, quarantine isolation and staying in place at home, because all work, all schools have been closed. And the postmodern is the enablement of the neighborhood level, very thorough execution of the stay-at-home orders, enabled by the social apps such as Alipay or WeChat, where everybody has, according to their own health declarations, along with other online data about travel, so that everybody has an imputed or inferred risk level, which is marked like a traffic light system. And it would basically indicate the radius of the activity that you are allowed under the statutory stay-at-home orders. Whether you can leave your apartment, whether you can leave your housing estate, whether you can leave your neighborhood. And then, of course, very good back support services, such as to shop for you, to make sure that you have the daily necessities and the supplies. And really that was one of the most striking appreciation that the whole team had. And secondly was a whole of government approach. Now, of course, mainland China may be quite different to some other countries, but the whole of government approach, both across different departments or ministries within the same jurisdiction, or vertically from the central government down to the provincial government, down to the city level government, down to the township level. Both ways, there was a whole of government approach and a very, very high level of attention to detail by the number 1 and the number 2 and the number 3 officials of any particular jurisdiction of any size in charge. So those were the two sort of most indelible experiences, I think I certainly, and I think many of my colleagues on the joint mission actually gleaned from that week or 10 days doing this mission.
Thanks for sharing that. I really like how you put it, the combination of the medieval and the postmodern. What we're seeing now in Singapore as well as other places is that we are on the verge of lifting the lockdown. Is it inevitable that we will see a second wave of infection following lifting of the measures? And what are some of the things that we can do to limit the second wave?
I think that one has to understand we've got a highly transmissible virus that is novel, i.e., there is no pre-existing immunity in humans. And combined this high transmissibility with a basic reproductive number of somewhere between 2.5, or maybe even 3, although I would hasten to add that there is a lot of clustering that is characteristic of these newly emergent, at least, coronaviruses. Certainly the case with SARS and MERS and COVID-19. Now, if you say that they are very highly transmissible, on average, a typically infectious individual would pass it on to 2 or 3 people, then you add in the pre-symptomatic transmission of up to 40%, that is almost 40%, or even just a little over 40% of all infections were spread by the index cases during the incubation period, when they had no idea that they were infected or sick. Put those two together, that should actually tell you it's almost impossible to control completely. Therefore, nobody has really talked about containment anymore. Everybody's talking about suppression, but not containment, not elimination, and most certainly not eradication. Now, but one sort of caveat is the clustering effect, or the super spreading potential, where the latest evidence from Hong Kong is that about 20% of infected indexes go on and are responsible for 80% of the total number of cases. That means that if you are able to identify those 20% rather more infectious individuals, or at least individuals who may be typically infectious but in highly susceptible or infectious settings, then you could devote just 1/5 of the effort otherwise into actually trying to mitigate or suppress the outbreak. So I think all that put together, my guess is roughly half, give or take, of the global population would need to have immunity before we could stop it, or that this would settle down. Now, how would you get immunity? There are only 2 ways. One is through natural infection and recovery in most cases, or through inoculation with a safe and effective vaccine. And so that's why it is almost a statistical certainty that you will get a second wave. Now, of course, much empirically depends on what is the level of seroprevalence, that is, seropositivity of people showing protective or neutralizing antibodies after the first wave. If that number happens to be in the single digits, then I'm afraid there is still quite a ways to go. But if it's double digits, or even in the 20, 25+%, then maybe we would have a less susceptible population. Because always remember, my fourth point is that the most susceptible, whether it's by exposure or by host characteristics, would have been swept through and got infected in the first wave. So the second wave has a slightly higher threshold in order to infect the remaining susceptibles. Yes. So those are the dynamic interplay of the factors involved. But I do think a second wave is almost inevitable.
Right. And this is a related question. It comes from Eileen Haw, who is from Singapore National Healthcare Group. And her question is this: it looks like the second wave, as predicted, is now coming around. Could you share with us some of your models of the subsequent waves? What would they look like based on your projections?
Nobody knows. Nobody has actually done second wave projections in terms of the waveform, because we still don't have good enough input parameters in terms of what is the depletion of the susceptible population during the first wave yet, and in what age groups. We're now beginning to understand, and we're now beginning to see some better evidence of the relative age susceptibility. We are guessing, making better and better guesses of the age-specific infectiousness profile. So those are the input that you would need, but critically, you would need to know what is the proportion of people who already have neutralizing antibodies after the first wave. Once you know all these things, then maybe you can try to work out what a second wave may look like. But I dare say that it probably wouldn't be catching as many governments or populations as off guard in as many places as the first wave had done. And so hopefully, if governments and populations have learned lessons from the first wave, then they might actually decide to do frequent switches between suppression and lift policies such that they could mitigate the impact of a second wave.
Right. And what is your opinion on opening the schools? What evidence do we have to look for in making a decision on whether or not to open?
I think that, again, it would be two factors that you need to consider. One is from an adult or teacher perspective, or carer perspective, or parental perspective, the duty of care should be the principal. And the duty of care, translated into epidemiological terms, would be how susceptible are children to getting infected or getting sick when infected. And notwithstanding the very rare observances of the Kawasaki-like multi-organ inflammatory syndrome in some selected children, but particularly in the West, we haven't seen very much of it in the East, or at least not reported yet. Notwithstanding that, for the vast majority of children, it does appear that they are less susceptible by quite a significant margin compared to adults. So from a duty of care perspective, if you allow adults to go back out into the community, for example, to go back to the workplace, then allowing children to go back to school, given that they are not nearly as susceptible to getting infected, let alone getting sick when infected, because they are less likely to get sick even when infected as well, it appears. Then from a duty of care perspective, you have probably satisfied that criterion. Then the other side is, are children as infectious, more infectious or less infectious compared to adults? For influenza, we know that they are very infectious because of their personal behavior, hygiene, and social mixing and contact patterns. For coronaviruses like COVID-19, we don't know. But we are beginning to have different shreds of evidence that we are beginning to triangulate. And maybe the upper bound is that they may, at worst, be as infectious as adults and possibly less infectious as adults, which means that even on that count, in terms of whether allowing children to mix in schools is going to lead to a societal decrement, doesn't appear to be the case either. And therefore, maybe if those pieces of evidence are beginning to be substantiated and pass peer review over the next few weeks, then maybe in a month's time, we would be in a better position, if these are substantiated, to come to a sensible conclusion, evidence-based conclusion about school closures.
Right. So if I could summarize that, you are saying that the evidence, even though it has not been fully published yet, seems to suggest that children are less susceptible and they're also less likely to transmit the virus. So would you, based on those things, say that opening the schools is probably not a very high risk event?
Well, relatively speaking. And of course, we learn from the Singaporean experience as well. Even though in the latter part of your first wave, there is large outbreaks in the migrant workers' dormitories, but in the general community of Singapore, um, you actually kept schools open for a very, very long time without any substantial community transmission up to this point, actually. So I think that that would be, of course, the ecological view, which is, of course, susceptible to ecological fallacy or bias. But I think that we also need to take a look at those issues. Taiwan, similarly.
Could you explain what you mean by ecological fallacy?
That is, you see that amongst all the things that Singapore has done, at least in the general community, disregarding for the moment the migrant workers' dormitories, there's never really been a sustained local outbreak up to this point. And yet, only in the last few weeks have you closed your schools because of the dormitories outbreak, not because there is a sustained local community outbreak. So that is at the ecological or at the phenomenological level. That is not some inference that you make from a model or from inference drawn from actual empirical data.
Right, I see. Okay, and when it comes to reopening the economy, one thing that people would need in place or governments would need in place is testing capabilities. So we've seen that in China with Wuhan, they are starting to see a second wave right now. And just in the last 2 days, Monday and Tuesday, they've successfully tested 800,000 people. But for other countries, what would you say is the minimum testing capacity that a country should have before it considers lifting its lockdown?
Well, I don't think there is any magic number. I think that test and trace are the fundamental underpinnings to quarantine and isolation. And therefore, that's why test and trace are so important. But the testing bit, for a population like Hong Kong, where we have 7.5 million people, our goal is to, in the public sector, supply about 7,000 tests per day. Now, of course, we are also encouraging and incentivizing the private market to perhaps even double that number. So that gives you, on a per capita basis, what we're doing in Hong Kong, which is actually on a per capita basis very similar to the rest of mainland China, and also in South Korea. So I think that those might be some benchmarks that might be useful for other populations to consider. But there is really no right or wrong answer. The right answer is really as many as you can under the circumstances, leveraging both the public and private sectors together.
Right. So test and trace are the two main things that need to be in place before we lift the lockdown. And you've just mentioned that, of course, as many tests as you can a day. Moving on to trace, you mentioned earlier that robust data through the contact tracing apps in China were one main reason why they were able to contain the outbreak so well at the start. But in other contexts in other countries, how important do you think contact tracing apps are, and do you think they are worth the privacy trade-offs?
I didn't really point to the contact tracing apps of mainland China, but I think that contact tracing apps can be a useful adjunct, but contact tracing apps alone are probably insufficient because, number one, they need to have an uptake of around 70-80% for it to be of any use. Secondly, contact tracing apps can only tell you geospatial resolution as much as the Bluetooth radius allows you to, and of course, sometimes it's very difficult to tell the nuances of the different types and intensity of contact beyond the geospatial. And you would still need the human touch of trained tracers who have worked on other outbreaks in public health departments previously. Now, of course, you say, well, we don't have that kind of capacity for this kind of outbreak. Then you would need to do a lot of training and quick training and redeploy people accordingly so that you really beef up on that tracing capacity.
Right. And you mentioned earlier that we don't currently know enough about the sustained antibody response from patients to really make a lot of decisions. But clearly, this is something that is important, and a lot of researchers are trying to find out right now. But in your opinion, people who have been tested to have neutralizing antibodies against SARS-CoV-2, do you think that they should be issued what is called immunity certificates?
I think that would be very, very careful. I think it depends on the test characteristics inherent to the test that you use. Secondly, I think that it really depends on the expected or anticipated prior. That is, what would you expect the prevalence to be at the time of the testing? Because the predictive values are heavily affected by the prevalence at screen. Thirdly, you have to deal with fraud. You have to deal with the perhaps perverse market of buying and selling these so-called immunity certificates. You would have to deal with privacy issues. You have to deal with social stigma issues. So I think that there is quite a lot to deal with before one should consider going down that road. And in fact, in a couple of countries, one in particular, in Latin America, the government announced that it would be going in that direction and was ready to issue immunity passports or certificates, then had to pull back because of many of the concerns that I've just raised.
Right. So what I'm hearing is that it is probably not a good idea right now, as it's not definitive enough an answer.
Well, as I said, I have laid out the conditions under which it might work, and there are some issues to be ironed out. And I think that, the ethical, legal, and social issues are non-trivial, and we do need social scientists and legal experts to help us to think through the issue if we want to go down that road.
Right. I have one question here for you before I open the floor up to the Q&A. I would just like to ask, personally, are you hopeful that global solidarity will prevail against nationalism in shaping a post-COVID-19 world?
No, I'm not. I'm very pessimistic. Judging from the responses of different countries along different geopolitical axes and looking at the overall global response so far, I'm not hopeful. But I live and pray in hope nonetheless. So usually I am an optimist, but an optimist who worries a lot. I think on this count of one big happy global family in solidarity, hand in hand with each other post-COVID, I think that would be a little bit or one step too far to expect. And I think that we need to prepare for a rather less rosy scenario so that we could shift that arc of justice back in the right direction. COVID-19 may well turn out to be one of the gravest inequities in health in recent memory. And I think that if this does indeed turn out to be one of the gravest or the gravest health inequity of our era, then it's not so much by commission, rather omission. That is, we are not proactively working towards making sure that the less advantaged groups within our own societies, or more generally, low and middle income countries around the world, do not bear a disproportionate burden of COVID-19.
What are the most urgent steps that we can take to ensure that COVID-19 response doesn't become such an unequal response and such a great unequal health differential for the world.
We must make sure that access to care is universal. We must make sure that this universality is not complicated by means of payment, regardless of what the status quo of the health system concerned may be. We must make very sure that the distribution of any personal protective equipment, whether it's face masks, facial coverings, or indeed any other hygienic practice equipment, are along pre-existing, prejudicial socioeconomic gradients. We must also make sure that vaccines that are safe and effective are distributed fairly amongst all, between and within countries. And of course, the availability of tests and therapies. So this is a tall order, but this is a true mark or metal for our leaders to rise up to.
So you mentioned the equitable distribution of PPE and other hygienic measures, a vaccine if and when it is available, and treatments and diagnostics as well. How can we go about ensuring that it is fairly distributed, given that every country is interested in securing supplies for themselves?
Rudolf Virchow said it best. Doctors are responsible for diagnosing and pointing out the problem. We need to leave it to social anthropologists, i.e. politicians, to come up with the solutions.
Right, I see. Certainly a very difficult task. A question that was very popular in the webinar questions that was submitted earlier was that a lot of people were interested in what Hong Kong did differently to manage its own outbreak response. What can the rest of the world learn from how Hong Kong handled COVID-19?
I think Hong Kong, along with colleagues in Singapore, in Canada, in mainland China, we all shared the indelible sociological imprint of SARS. And that's what really prompted us, like you, to start very early. And it was complemented by a very willing and, frankly, worried population. And that's why I think the personal behavioral changes, like wearing face masks, like avoiding big crowds, like complying with physical distancing directives, I think these are all very important. And that's really a legacy of the post-SARS effect. Plus, of course, I think that many of the government policies and interventions that are layered on as the epidemic progressed were all, or at least as much as possible, based on the best science available at the time. And really, it has been a science-led response so far, and long may that continue.
So on to this science-led response, what are the next most urgent questions science needs to answer about SARS-CoV-2 and COVID-19 so that we can contain it better?
I think clinically one needs to understand much better the pathogenesis of some of the clinical syndromes that are less common but very severe. The children Kawasaki-like disease, the aftermath of even recovered patients, especially amongst those with pre-existing conditions or who are in older age groups or who may not have the full physiological reserves of younger folks. I think that those are still unanswered questions. I think on the sort of immunity or immunobiology front is to really better understand how the immunobiology works, the cross-reactivity of the antibodies, the correlates of protection other than the neutralizing antibodies themselves, the involvement of the T-cell response, of the cell-mediated immunity response, and of course extending that to vaccination and the biology of the different half a dozen main platforms of the vaccine delivery and the safety and efficacy of those vaccines. And then, of course, the distribution. how would you, from an operations research point of view and an ethical point of view, how do you arrange the distribution? And I think that, those are another set of issues. From the public health front, how do you deal with a second wave, possibly a third wave, and the different suppression and lifts, which is always a three-way tug of war between health protection, economic preservation, and social acceptance and emotional well-being of the population. So I think all those things are still major unanswered questions which require answers.
Right. Okay. We have a question now from the Q&A. This comes from Meng Chon Lam, and he asks, would you be able to comment on Sweden's no lockdown approach and their justification to minimize the second wave? Thank you.
I think that we really don't have the final answer yet, but if you take a cross-sectional cut and take today as a censored observation, then the per capita number of deaths doesn't bode well compared to its neighbors. But, of course, if at the end of the day, after 2 waves, 3 waves, 4 waves, until the vaccine arrives, assuming that it is effective, then that may change the picture. Really, nobody knows yet. But the big question is actually a political one, or one of social consent at least. That is, should one be willing to absorb a large proportion of the so-called hit in the first wave when so much is still uncertain about the science of the disease?
A good point. We don't know enough, I think, to make that call. We have another question here from Anand Andiapan. And he asked, do you think that the second wave could affect certain demographics more than others? For example, in Singapore, the dormitory workers or people in the nursing homes and so on?
Well, I think that the susceptibility doesn't change. The setting may change. So it depends on where the seeds, the initial infectious seeds are. So I think that, the biological susceptibility of the host is not going to change because those have been fairly stable and constant in multiple studies. But depending on the setting and how you actually layer on your non-pharmaceutical interventions to try and mitigate and to suppress, that is going to determine whether you're going to get large clusters in, say, old age homes, which you have seen a lot of in parts of Europe as well as in America, accounting for a large proportion of the deaths, by the way.
Yes. A lot of what seems to be the exit strategy from the cycles of suppression and lift seem to really rely on there being a safe and effective vaccine. For you personally, how optimistic are you that we will have this safe and effective vaccine within the next 12 or 18 months?
I don't know. I'm, in this instance, a cautious optimist. But I think that we should also bear in mind that we don't need a perfect vaccine, because if we think of a symptomatic case fatality ratio of around 2%, which is what we published already 6-8 weeks ago in Nature Medicine, and assuming that the symptomatic proportion is roughly 50%, then you are looking at about a 1% infection fatality risk. That means that out of 100 people who are infected, 99 are going to be fine. They're going to recover. They're not going to die. So you don't really need it to be a perfect vaccine because most people do okay. And that means that perhaps what we need the vaccine most to do is to reduce the serious complications, including, of course, death. If you have a vaccine that is not perfect, but can at least take out the serious complications, including deaths, that would be a major advance already.
And how likely do you think we will get such a vaccine?
I don't know. I'm not a soothsayer, so I prefer to follow the science when the science becomes available.
Sure. Okay. And on a related note, how would you incentivize the private sector to administer tests? This is a question from Lucienne Angelique Bernal.
I think that governments can encourage large corporates, especially those who have large retail operations with many workers who have intense and frequent social mixing or contact with the population. that is to protect the occupational health of their own workers, as well as the general health of the community in terms of community transmissibility. So you can think of the large transport operators, you can think of the large supermarket chains, you can think of airlines, amongst many, many other types of industries.
So that would be government pressure on them to test their employees before allowing them to resume work. Is that what you're suggesting?
I think that the private sector should, in their self-interest, be doing such things already.
Right, I see. Okay. We have another question here from Paz Cruz Tayak. And this person asks, for a third world country with very limited testing capacity and poor technology for contact tracing, is a lockdown the only viable option to slow the spread of the virus? And how long can an economy realistically stay on lockdown?
Well, it depends on the context, doesn't it? How much reserve you have economically to stay in a lockdown. But if you have got very, very limited testing and tracing capacity, then I'm afraid you would have to use physical distancing in extremis in order to interrupt those pre-existing transmission chains, and then make sure that you prolong your border restrictions and do not allow any new infectious seeds potentially to enter your population.
Right. So it does seem to be that if you don't have enough testing and tracing capability, social distancing or lockdown type measures would be the main way you can respond. So I think with that, there are still a couple of questions, but we won't answer them at this point. So I'd just like to thank all the guests today for their active participation. This Friday, we will have another webinar, this time with Michele Wucker, the author of the best-selling book, The Grey Rhino. And the following Friday, following Wednesday, we will have another session with mental health expert Dr. Gia Sison from the Philippines. For the full listing of our upcoming webinars, including with Wikipedia's founder, Jimmy Wales, on the 3rd of June, please visit asianscientist.com/events. Finally, I'd like to thank you very much, Dr. Leung, for taking the time to answer our questions today. It has been personally a very illuminating session for us.
It has been a huge privilege. Thank you very, very much, Rebecca. And thank you to everybody, the 150 plus people who have logged on. And good luck, and in solidarity with everybody.